Prioritising Pelvic Health. Webinar recording hosted by the Alliance and Scottish Government.
So for those of you who may not know me, my name's Irene Oldfather and I'm Director here at the Health and Social Care Alliance, and I'm supported in our work around the Women's Health Plan by Jen Stewart, our Senior Development Officer, who's done most of the work and the technical effort behind today's session. As I think many of you will know, the Alliance works very closely with Scottish Government to support the Women's Health Plan. And as part of this work, we are committed to ensuring that information about women's health is widespread and that we're able to have open discussions about women's experiences and to try to remove the stigma and actually some of the myths around women's health. And I suppose all of us, have had or know someone who has had issues with the pelvic floor. And that's actually quite a common experience for many women and sometimes relates to life events like aging, having a baby, periods actually. But I don't think we talk about things in relation to women's health generally, pelvic health in particular, enough. So despite sort of common things associated with pelvic health, like incontinence, prolapse, which can be very debilitating for many women, I don't think there is quite enough knowledge about pelvic health, and that's why we wanted to spotlight that today. And we have with us today Jenny Munro, who's an advanced physiotherapist from NHS Highland, and I'll say a little bit more about Jenny in a moment. But maybe I could just let you know some of the sort of aims of the session today. I mean, what we want to do with you is to share information about pelvic floor muscles, the risks of pelvic floor concerns, and how to be aware of the symptoms, so that you have some sort of clear information. We can clear up some of the uncertainties around pelvic health, and that you have information to help you to self-manage. And I think one of the important things around women's health generally is to know when to seek further support and help. Because I think too often we suffer silently at home as women. So again, today's session will hopefully give you pointers as to, what are things that you can self-manage yourself, what are some of those issues, and how can you improve your pelvic health, but also when to seek support, and to give you a little bit of confidence about being able to speak about pelvic health without being embarrassed, and how to maintain, I suppose, good pelvic health. So now can I introduce our speaker for today? And Jenny, we're very grateful for you joining us. Our main speaker is Jenny Munro, and as I mentioned, she's a physio, an advanced physio actually, with 20 years of experience at NHS Highland. And has been working with patients with pelvic floor issues for a very long time. And I know that Jenny's passion is about patients at the heart and being very patient-centred in the work that she does. And that has brought her into the realms of evidence-based medicine and realistic medicine. And she's a strong advocate of people at heart and people as experts in their own health and well-being. So this is almost accidentally, she tells us, turned into working on some big national projects which hopefully will improve awareness of pelvic health issues and for people to, as I said earlier, understand how and when to seek treatment. So Jenny's going to talk a little bit about pelvic floor muscles, as well as provide information about public health concerns in relation to pelvic health, incontinence and prolapse. And there'll be an opportunity after Jenny's presentation to ask a few questions, and we'll come back to that in a minute. But for the moment, over to you, Jenny.
Thank you very much, Irene, and thanks so much to Niamh for supporting this today. Thanks for that kind introduction. My name's Jenny Munro, and as Irene said, I started with the NHS when I was in the Brownies. I've spent most of the last 20 years working with men and women, but today we're talking mainly about women, or people with female anatomy, as we like to talk about in our world. And like all pelvic health physios, I'm extremely passionate about putting my patient at the centre of their treatment journey. So along with understanding a bit more about your bodies today and what can go wrong with your pelvic floor, and if you do need to seek treatment, I'd like this session to help you get the best out of your appointments, because it can be quite daunting seeking help. We know on average most women will take a minimum of 10 years to seek help. And I want, when you get there, to get your best value for money, because I appreciate we do have long waiting lists. And when we get you in, I would love you to know the right way to do your appointment to get the best out of it. Lots of people say to me, well, why physio? Well, basically, we're talking about the pelvic floor, which is a big, thick group of muscles sitting at the bottom of our pelvis. If you think about a Coke can as your sort of thorax area, your middle area, the pelvic floor is the bottom of that can. Other fizzy drinks are available. And we are trained, we have additional training over and above our physio degrees to work specifically with patients with these problems. Your physiotherapist might be called a practitioner with special interest, a specialist, highly specialist, an advanced practitioner, or a consultant physio. And that's what it says on their letter. When you meet them, they'll say, hi, I'm Jenny, I'm your physio who'll be looking after you. And this title just depends on their additional training. Essentially, we have the same core training and a passion to help you get yourself better. And we want to empower you to do that, to live your life to the fullest, regardless of your age and regardless of your stage in life. Lots of patients have come to me in their 60s, 70s, 80s, 90s, and I've even got a few 100-year-olds better. So maturity is no barrier to getting better. Your physio, like me, might have the term non-medical prescriber after their name or on their letters. And this means that we can review your medicines and we may stop or add new medicines in. And this is done following a detailed discussion with you to teach you about your medicines, make sure you understand any changes, and we will always speak to your GP or consultant about this. So what I've got here now is a pelvis model. Now, anybody that has ever been into the doctors or the physio, some of you might already have had a physio, will understand that everybody's pelvis always falls apart at the most inopportune moment. And mine fell apart right before we started here. So I'm really sorry about that. So in between dealing with the Zoom drama, I was trying to put my pelvis back together and failing. Don't worry, we're good with patients. It's just the models that are the problem. So when we're looking at the pelvis, we've got all the bones and it creates this bowl. And then we've got the layer of pelvic floor at the bottom. It's about 2.5 centimeters or a traditional inch thick and is about 14 muscles. This is the front and this is the back. This is the sacrum here, and the coccyx, of course, is just fallen off. That's the little bit here. It's in 2 parts. I'm so sorry about this, guys. When we have a look here, so if we have you up on the treatment couch and we're looking at you, we can see your bottom, your perineal body, your vagina. This is your urethra, or where you pee out of, and your clitoris is up the front here. And of course, you have a layer of skin, your labia, over the top. We will rarely talk to you about the different muscles because they work as a team. So we might sometimes communicate with your doctor about one muscle versus another, and we can go through that with you if you like, but we usually talk about them as a team. They are basically there to stop the bottom falling out of your world, so they support your vaginal walls and your bowel wall. They keep you continent, both from your bladder and your bottom, and they're very important in sexual function. So why might you end up in my clinic or one of my colleagues' clinics? I'm going to give a really big long list here, and Niamh has already seen this list, so hopefully she's organised for this bit. So you might come and see us if you have stress incontinence. This is where if you laugh, cough, sneeze, run for the bus, or perhaps are having an orgasm, some urine will come away. It might be a wee droppy, it might be an awful lot more, but that's stress urinary incontinence. You might have frequency and urgency. That means that you're in and out of the toilet an awful lot. I'm from the Highlands, so I say like a fiddler's elbow. Or it could be that it's a mad dash to get to the toilet. You might get there on time dry, but it's a close run thing. Some patients will tell me that they leak on the way to the toilet, and we call this urge urinary incontinence. You can have both of these, and we call that mixed urinary incontinence. And we will always ask you to tell us which is the worst one, because we're always interested in how you feel about your symptoms. Some patients will talk about needing to go to the toilet overnight, and this is very, very annoying if you can't get back to sleep. If you're under 80 and you're going to we consider it normal to go to the toilet 0 to 1 times a night, and over 80, 0 to 2 times a night is normal. So we might manage to get it lower than that in those age groups, but not always. Some patients will tell us that they wet the bed, and we call this nocturnal enuresis. And this is where we wake up and we've already started to urinate, or it's already happened. Patients with physical disabilities may struggle to get out of the bed and have an accident during that, but that's usually more like stress incontinence or urge incontinence, rather than for patients who start to urinate in their sleep. And we often spend a lot of time trying to figure out with you which is which, because it's important for us to understand. We may see patients with painful bladder syndrome, and if anyone on the call has got that, you understand how difficult it is to get a diagnosis and get to the right place for treatment. And I know we'll probably got some folks on the call with these issues. Some ladies might tell us about vaginal prolapse. This is where the vaginal walls have become softer and they stretch down a bit. You can have this at the front wall, the back wall, or the top of the vagina can come down. We call that the vault in patients that have had a hysterectomy. Lots of patients will say to me, but how can I have a prolapse? I've had a hysterectomy. Well, the womb sits above the vagina, so even if you've had a hysterectomy, you can still get a prolapse. And in my experience, you usually come with more than one. So the front wall and the back wall might be down, or all three might be down. And patients will talk about a feeling of heaviness, a dragging feeling. There might be a bump that you can touch, and it'll vary from day to day. If you've had a busy day on your feet, you've been lifting heavy things, you've been constipated or straining at the toilet, you might feel that your prolapse symptoms are worse, and then you might have a nice day lying on the sofa reading your book, and it's not bothersome at all. So everybody will experience these symptoms differently. So we're moving towards the back of the pelvis now, and we're on to the bottom here. People might experience fecal urgency. So it might be a mad dash to get to the toilet to empty their bowels, but they can get there on time. Some patients might not get there on time, and we call that, fecal urge incontinence. And that's absolutely, all of these are horrible, but lots of patients come in and they say that's the hardest symptom to talk about. I call it the final frontier. It's the sort of symptom patients tell me about on the way out the door. They pop their hand on the door handle and they say, one more thing. You asked about any problems with my bottom, and I was embarrassed, but actually, I do have a problem with my bottom. Some patients will experience seepage from their bottom when they laugh or cough or sneeze. Fecal stress incontinence, we call that. Some patients can't hold on to their wind, and we call that incontinence of flatus. It can be hard to empty your bowel, and we kind of split hairs in the hospital, and we talk about constipation differently from difficult defecation. And we have a classification, and we take you through all that. But if you're having a struggle to empty your bowel, you may still come and see a physiotherapist about that. Some patients will talk about having an intussusception or a rectal mucosal prolapse, and this is where that bowel wall isn't well supported and is kind of squidging down, and it gives a feeling of pressure at the bottom. And some patients will find that prolapse coming out of their bottom, and you may come and see a physiotherapist about that. And guys, we're not even at the end of the list yet. It's very busy in our clinics. We see a lot of patients with pelvic pain. So we're we differentiate here. We may have some ladies on the call that experience pelvic girdle pain in pregnancy. And if you were coming to see a pelvic floor physiotherapist, we tend to be looking at pain that's caused in the pelvic floor muscles. And our musculoskeletal colleagues look after ladies that have pelvic girdle pain. We may have patients with sexual dysfunction, and we do an awful lot of sexual dysfunction work. If you're one of the 20% of ladies who experiences painful intercourse, come and see a physio. Let us help you. Let us understand what the problems are and get some resolution for you. Well, that was quite a list, wasn't it? It can be very, very busy in our clinics. We see between 7 and 10 patients a day, and we could see a patient that has lots of these symptoms or just one of these symptoms. And never feel afraid to tell us about all of your symptoms. Don't think you're rabbiting on. Your first appointment with a physiotherapist could be over 45 minutes. And we want to know all about your problems because knowledge is power. The more we know, the more we can help you. If you need longer in your appointment, your physio might ask you to come back another day and book you a double slot because normally your second appointment's a bit shorter. But we don't have a problem with making an appointment longer so that you can get the most out of it. So you'll have your opportunity to tell your story. The physio might say, tell me what I can do to help you or what's going wrong. And you'll have the opportunity to talk. And then we'll start the nosy questions. And we'll get into the nitty gritty of what going to the toilet is like for you or these kind of things. You'll be asked to complete some questionnaires. And your physiotherapist will support you with that. And we double check these questionnaires at the end to see how we're getting on. You may be given diaries to complete. Now, we understand that these are a complete pain in the bottom. But your bladder diary and your bowel diary are such important tools that the best job you can do with those really helps us. It helps us with your diagnosis and working out your treatment. And in fact, lots of patients come back to clinic and they tell me, oh, I looked at my fluid diary and I can see I'm drinking too many fizzy drinks, too many caffeinated drinks, or I drink next to nothing and I fixed it and I'm very much better. Other patients, we take them through that fluid chart and we help them understand what's going wrong. We'll offer you a physical examination as well, and that helps us understand. I always say to my patients, I'm trying to match the history to the geography. So you're telling us your history, your story, and then we check the physical issues and we put the 2 and 2 together. And that's a very important part of the diagnosis. Not everyone is comfortable with an examination, and you'll always be asked if you want to do it, and you'll be offered a chaperone. A chaperone is a member of staff who's trained in the procedure themselves so they can reassure you that it's all been done properly. You'll be in a private room and the chaperone will be sitting next to you and giving you reassurance. You don't have to have a chaperone. You'll always be offered the choice though. When you're being examined, you just take your things off from the waist down. So you're not needing to worry about, getting dressed up fancy or anything. We just take your bottom things off, you lie up on the bed and you're covered over with some paper towel or sheet. So you have the illusion of privacy. That's what I say to everybody. It's the illusion of privacy. We know it's a very intimate examination and we do our best to make it as comfortable for you. We're usually pretty fast at it. And if you've been examined by a gynecologist or a doctor, patients often comment that their physio was a bit gentler. But don't tell the doctors I said that. Some patients want re-examined. Often I'll just examine my patients once, but you'll have patients who like feedback. There might be some of you guys on the call and you love feedback, and you'll be the patients that ask your physio to reassess you to let you know how you're getting on. Once the full assessment's been carried out, we'll always discuss with you what we're thinking based on your history. We'll explain the examination to you. We'll set you up with some exercises. And we talk a lot about what we call realistic expectations. So we look at what we found, what you're looking to achieve, and we talk about what's realistic out of that. On average, I see my patients usually between 4 and 6 times over 6 months. But the great thing about this is it's unique to you. So it's totally unique to you, and your treatment will be tailored to you. So what can I do to improve my symptoms? You might be a patient on here or a future patient. You've not yet sought help. Well, there's lots of things that you can do. Have a look at what you're drinking day to day. Okay, have a good think about it. Caffeinated drinks, fizzy drinks, too much chocolate, I'm afraid, because there's lots of caffeine in chocolate, and alcoholic drinks can cause a bit of irritation in the bladder. And the one that nobody ever knows about is artificial sweetener. And it's very hard to avoid in modern day life, but some patients will find that causes frequency and urgency. So swapping to decaf tea and coffee, keeping the fizzy drinks and alcohol for treats can be very, very useful. And that's very helpful. Starting your pelvic floor exercises is a good idea. Or if you've been a patient before and you've slacked off and fallen off the bandwagon, dig out your booklet that the physio gave you and restart them. We're not super keen on teaching pelvic floors if we've not examined you, because physios are fussy and we like to make sure your technique's correct and that we've given you a really personalised training programme. But the sensation that you're going for is to draw up at the back passage like you're keeping wind in and imagining you're stopping mid-flow of urine. We never ask you to do that, but that's the sensation you're going for. You should see if you can hang on and then relax the muscles and see how many of those you can do, and then do some quick ones. Nice and fast, just up and down. There are very useful apps out there, things like the Squeezy app that was written and designed by a physiotherapist called Myra. She works in London. She runs one of the big services in London, and she wrote this fantastic app. I'm afraid it does cost a few pounds, but for patients who aren't very good at remembering their exercises, like me, I'm a terrible patient, they can be very, very handy, these sorts of things. Or if you're like my mum, she just cancelled it because the notifications really annoyed her. And don't tell her I mentioned that. Staying active is really important. And lots of people worry that if they've got incontinence that they can't be active. Well, I'm here to reassure you that walking, swimming, riding your bike is as good exercise as any. I always recommend Pilates to anybody with pelvic floor muscle problems, because that really gets that pelvic floor up and going, really works your tummy muscles, really works your back and bottom muscles. And going to the gym can be very intimidating. So if you're not into that sort of thing, don't worry about it. We're not going to ask you to start, but we will encourage you to be a bit more active. Now, if you're like me and you're a little bit cuddly, everybody knows they're a wee bit cuddly, and it can be very, very hard to lose weight. So if you're in that camp, ask your physiotherapist or doctor for some advice and support on losing weight, because it's one of the best things you can do. I had 2 patients once. They were in the same week and they'd come in for their first appointments, and they went away and they came back in 3 weeks. One was on Thursday and one was on Friday, and they both told me they were cured. And I said, here, I'm pretty good at this, but I've never got anybody cured in 3 weeks. What's going on? And both ladies they were having different life things going on, and they both lost half a stone. I hadn't mentioned it because I don't like to talk about people's weight. But after that day, when the 2 days they came in and told me they were very much better, I've started telling everybody it's an important thing to do. Even just a couple of pounds can make all the difference in your symptoms. And I know how hard it is because I'm cuddly. So keeping well hydrated. I've separated this from fluid advice because there's lots of myths out there on fluid. If you look in a physio department, you'll see everybody dragging these massive big water bottles around. You don't need to be drinking tons and tons of water. You want to be well hydrated. We call it the Goldilocks moment, not too much and not too little. For the vast majority of people, somewhere between 1.5 to 2 litres of fluid is absolutely perfect. Don't be worrying about more than that. If you're working in a really hot environment, you've been in the sauna, you're on a lovely foreign holiday where you're sweating, definitely drink a bit more. But for those of us that are in a slightly grey Scotland, 1.5 to 2 litres of fluid is absolutely fine. It's very important to not strain at the toilet for your pelvic floor. So if you're a person who's prone to constipation, or you find that in your menstrual cycle, a couple of the weeks of the month it's a bit awkward, really looking at your fibre and fluids in that time are important. I always recommend looking at Squatty Potty, and they've got a very, very funny YouTube video that don't watch it with other people, just watch it yourself. But when you see it, you'll understand why. And that helps you get into a good position for emptying your bowel. I once had a patient come to see me who had been straining at the toilet for 50 years and nothing had ever helped. And we got her better in 2 visits. Now, we can't do that for everybody, but sometimes just tiny little tips based on what we see on your bowel diary or we find on your physical examination can make all of the difference. Don't lose heart is always my message with this. Your physio is there to support you. So if you're feeling a bit down or a bit miserable about how your treatment's going, let us know. Don't be suffering in silence. Because we've got little tricks and things that we can do to help. And we base it all off your examination. But if you're feeling a wee bit down about it all, keep talking to us, because the more we do, the more we can help. We might have some folks on the call today who have chronic respiratory conditions. And unfortunately, a chronic cough and pelvic floor problems go hand in hand because of that constant pressure down below. Before I specialised in pelvic floor, I was a respiratory specialist and I was lured away. So I know an awful lot about the middle of the body and not very much about the arms and legs. I didn't do much of that kind of physio. So I'll often talk to my respiratory patients about managing their cough, optimising their medicines, and plenty of folks I send back to the respiratory clinic for a review. It's really important that we work together as a team if you have a couple of different health conditions. And don't let that put you off coming to see us. That's for us to worry about, not you, but we can manage that. We are very keen on you taking up your routine screening. So if you're offered a smear test, please still take that, because there's a couple of treatments that we offer that we need to know that your smear test is clear and up to date. And unfortunately, we don't offer it in clinic yet. Lots of ladies say to me, well, I'm coming in for an examination. Could you just do my smear test? And as Irene said, I get involved in all sorts of national projects. And one day I might finally pull off that physios get to do your smear test, because it would make everybody's life much easier. We encourage you, although it's not really related to this, to have your mammogram. And when you reach 50 and you get that special parcel through the post, please do your bowel screening. We will ask you in clinic, and of course it's your choice if you don't want to do it, but we do encourage it because bowel screening really does save lives, as does cervical screening. It wouldn't be a health talk if we didn't encourage you to give up smoking. We like you to still have fun and do the things you love, but it's always a good idea to give up smoking. And it's not for the reason you think. It's not just because of the cough or the lung cancer risk. It's because the byproducts of smoking end up in your bladder, and they can make your bladder really, really irritated. And we've seen lots of patients over the years get very much better when they've stopped smoking. Now, folks, I've kind of raced through that a little bit, but what I'd like to do is turn my attention to the questions, Irene, if we've got any questions coming in. I can't see them popping up, but I'm sure a few folks have a couple of things to ask me, because I'm quite sure I'll have missed something out, guys. So please don't be shy and make sure you ask me something that I've missed out. Well, you're on mute.
Thanks so much. Thanks so much, Jenny. That was just like so informative, and you've explained things with a great sense of humour and such an easy way. So thank you for that. And we do have a few questions, and I noticed there are some things in the chat, a few questions. Could I encourage you, if possible, to put the questions in the Q&A? But I'm keeping a close eye on the chat, and I've already picked up a couple of things from that. So I suppose one of the things that's coming through, both through the chat and the questions, Jenny, is around accessing services like yourself. I think you've sold yourself so well. Everybody wants to come and see you. Is the problem now?
It's a little tricky to come and see me. My job, sorry guys, we had a bit of a Zoom issue at the beginning. I know that Irene introduced me in as an advanced prac, and I kind of run a service. So unless you live somewhere in Highland or Guyland Butte, and unless you're having a really rubbish time, you don't get to come. You have to be having I hope none of you are having a bad enough time to get to see me.
Well, I think a few people are, but let me just pick up some of the points from the questions, Jenny, and a few relate to access. So I'll just throw them out there and you answer
Go
them
for it.
as and when you can. So there are some questions about consistency of access, and it appears that in some health boards, you go through a consultant or a GP. Is it the case that in other health boards you can self-refer?
In
And
some you can.
And the question is, you know, how do we support widening access, and why is it that in some health board areas, you know, you can self-refer and others you require a GP?
It really comes down to how the team is set up, really. So when I worked in Glasgow, we didn't have self-referral, but our GPs were our fight. We had to send the Marks and Spencer's vouchers for Christmas because they kept us so busy, our GPs, that about 50% of our work was GPs. And they knew us and we knew them, and they were very happy if anybody hinted that there was a problem with their undercarriage. They were in the pelvic health physio clinic before you could say Jack Robinson. And in other areas, they've just found it easier to do a self-referral. There are a couple of things we like checked. So often it is, I know people think, oh, I can't get a GP appointment, blah, blah, blah. But sometimes if you describe certain symptoms, we want the GP to have checked a couple of things. So if you come straight into physio, quite often you're sent back to your GP to get some things checked before we can carry on. So it's kind of horses for courses, really.
Okay. So again, sticking with access, and I don't know if this is really one for you to answer, but I'm going to throw it out there because it's been put in the chat, and that is around information around private physios. And I know our colleagues from the Pelvic Partnership are on the call, and I don't know if there's anything you want to say.
Well,
Jenny,
I can answer this one. I'm very allowed to answer this one because we believe in equity of access. So if you phoned any physio department in the country, in Scotland, I can say this because of some of my national jobs, most of us hold a list of local providers. So if you phoned up and you said, I can't bear to wait however many weeks the wait is, we will tell you where the local providers are. So you're very within your rights to do that, and we have absolutely no problem at all with doing that. And that's a sort of enshrined thing.
Well, that's great, because Heidi, it was, who put the question in the chat, says that she's not been able to obtain that from local physios, but that'll give her a wee bit more confidence maybe to go back and ask. So, and
sometimes it might be maybe the physio's new in the area. You know, when I moved home, so I'd worked in I'm Highland through and through, cut me and a bleed tartan, but I'd worked in Glasgow for a long time, so we knew all the local guys. We could have told you the first name of the physio, the name of their dog, and what their favourite colour in cake was in every clinic in Glasgow. And we could say, well, they're there on a Tuesday, they're there on a Thursday. You know, you got far too much information on the physios there because we knew them all. We could say, now take them in a wee lemon drizzle. But in different areas, you know, maybe younger staff haven't, you know, learnt that bit yet, or they're less experienced in the area. You know, when I moved home, I was playing catch up with what local services were. So the POPG website and Julie Bond's organisation, which is gone, because I'm on the spot here, is going right out my head. Maybe the Pelvic Pain Network, they're called. There's those kind of lists of local services.
Well, yeah, and there's Pelvic Partnership on the line too, and I think they've put some information on the chat. So, so you know, good to hear that. And of course, we will always post people to NHS form for further information.
Well, I mean, you'll see Caroline and I's video on there, which will give you some bits and more in-depth advice than we've given on this call, just slightly different. But that was my YouTube debut, guys. I've been telling everyone, and I'm an influencer now.
So a couple of very practical questions just to put to you then, Jenny. So one lady's waiting for her appointment with a physio, and she's wondering, it was good to hear about the importance of exercise, but she's wondering, should she wait until she has a proper diagnosis, or should she continue exercise just while she's waiting?
I'm going to give you the absolute physio answer here, and that is, It depends. We love a vague answer. What I would always say is it making your symptoms worse? Is it making your symptoms worse? If it is, swap to something else. You know, you might find that maybe it's a body pump class, or you're in a running group, or, you know, you and your pal are doing couch to 5K and you're thinking, oh my goodness, or you want to do the park run and you think, oh, my leggings are damp by the end of that. I don't like that. Swap to something else. Do the spin class, do the swimming, do something different. Just swap, you know, until you've been examined. That's the big thing. Is it making you feel worse? Don't do it.
Okay. And another very practical question, can I just say to people, it's good if you can put your questions in a general way rather than very personal. And also if you could keep them kind of short and to the point. But, you know, there's some great questions coming in. And there's a question here about an upper age limit for smears. I don't know if you feel you can answer this.
Yeah.
Jenny,
So I think now, again, off the top of my head, I'm going to say 65. And that the reason for that is, but you're more prone to a different kind of female cancer after that age. It might be 66. It does change occasionally. So please, nobody put on a forum that I was wrong. It changes from time to time. And it's because we're more prone to different cancers after that age. I'm not saying it doesn't happen. And if you are concerned, do discuss that with your doctor, of course, but the routine smearing is kept to that.
The lady in question is just saying, you know, is there a point beyond which it's not really helpful? So you're putting yourself through a bit of trauma for something that's really not going to help you. So I'm not so sure that the actual, you know, whether it's 62 or 65 matters. I suppose it's just, you know, is there a point at which beyond that you're not really helping yourself?
Yeah, it's, and I mean, I've had several patients who've really, you know, convinced their GP to carry on screening them. And there's all sorts of different reasons why people might feel like that. But as I say, there's other things that are more likely to go wrong, unfortunately, in maturity. And what I would say to any lady is be looking out for abnormal bleeding. If you haven't had if you're 2 years after your period and suddenly you start bleeding, straight to the GP. If you're finding when you're eating your dinner and, you know, normally you'd manage to eat the full plate before you feel full, and then you think, oh, I'm feeling full early, straight to the GP. Any weird discharge, straight to the GP. Weight loss, straight to the GP that you weren't, you know, if something's off, out of kilter, tummy feels bloated and it wouldn't normally, strange and unusual bleeding or discharge, GP.
Okay, that's very helpful advice. Thanks, Jenny. There's a question about the relationship between spinal injury and pelvic floor. Is there a relationship? Is that something that you work on jointly, or is it because you mentioned you're not arms and legs but your body, so I think you've triggered a question in someone's mind.
Yeah, I'm not arms and legs, I'm body. That's a good way of putting me. I used to do lungs, now I've gone south, is the way I describe to people. So we do, long story short. So, you know, I have a patient on the books at the moment who's a spinal injury, and we speak to people who are patients who've had a cauda equina. We might have some ladies on the call with that. I was teaching one day to nursing colleagues, and I had a very emotional phone call with a colleague afterwards because she said, you're the only person that's ever talked about it. And I've had many patients over the years who've had a cauda equina syndrome, and that's why they've presented. You know, so we see everything, literally everything.
And I imagine, I mean, many people will think, oh, if I see the physio, it's not as good as seeing the GP. But I think you've demonstrated today in the way you've described the time you're able to spend with patients, you know, the conversations that you're able to have with patients, that actually seeing the physio is a really, really good route into having things sorted. Again, a few questions around things like, you've spoken quite a lot about fluids and fluid intake and what to drink and what to avoid. And you mentioned something around it would be normal for someone over 70 to get up and go to the toilet once a night, and over 80 twice a night. And I suppose many people think, oh, I should try and avoid that. Should I not drink at night time?
I would say the cut-off is 3 hours before bed. Yeah, for anybody.
3 hours. Okay.
So I say to everybody, front load your fluids. Do your drinking during the daylight hours. And then, you know, if I don't want to be up for a wee overnight and I can get straight back to sleep, I don't have a cup of tea before bed, because what goes in must come out, ladies. So your 3 o'clock, your 3 a.m. peak, remember at night time, our production of urine slows down. So I didn't go into kidney function, but so during the day, our kidneys are working. At night, our kidneys are working. They're constantly working. They're part of our waste disposal system, and they must be working all the time. But when we're in bed asleep, we release a hormone that slows our kidneys down, and it's to give you those prolonged hours of sleep. Because everybody knows if you have a disturbed night, doesn't matter if it's with the kids, the dog, the neighbours being noisy next door. I live at the beach. It's the seagulls that are the problem. So if you don't get a good quality sleep, you're sluggish, grumpy, hungry for carbs. And the other thing is you can be going to the toilet for something to do. Try and avoid that. Try and avoid, well, I'm awake anyway, I'll go. Or I'm up with the baby, so I'll just have a pee just in case. Try and only go when you need to go.
Okay, and again, a question about pelvic floor muscles and cesarean sections. And should, you know, can cesarean sections impact? Should you do anything differently in terms of the exercises you've described?
So when you have one cesarean is protective of your pelvic floor. But if you have 2 or more cesarean deliveries, you have the same risk factors for pelvic floor dysfunction as ladies who have had vaginal deliveries. And whether or not that was vaginal on its own or vaginal plus instruments. So any ladies on the call here might have had a forceps delivery or a ventouse, which is the kind of suction thing. These are ladies who tend to, you know, present with pelvic floor problems because of, you know, it's been a more difficult delivery. So usually when you have a cesarean, you get your special cesarean booklet and it'll talk to you about your tummy exercises. Now, I'm not an expert in these because I don't do any maternity work, but you'll be given some special tummy exercises and you'll be told to do your pelvic floors because, ladies, it's a Nike advert, just do it. We want everybody doing their pelvic floors.
Okay, that's good advice. And a lady talking about working the night shift, and I think possibly your information about the kidneys are always working, you know, addresses this as well, Jenny. But she's asking, you know, should she not be drinking at night time when she's working the night shift? But I guess your body's adjusting.
Yep. So you will still be, whoever, that's an excellent question, whoever that was.
That was Vanessa.
Well done, Vanessa. So your 3-hour window becomes whatever is your 3 hours before bed. So whatever time the shift finishes, you jump in the car, you get on the bus, you go home. So whatever bedtime, if bedtime's 9 o'clock in the morning, you finished your drinking at 6 a.m. It's no different. You just move it.
And there's a question that's a bit technical. I don't know. It's about vaginal atrophy in the elderly. You know, how would you suggest dealing with that? And does that relate to what you've discussed?
This is a super... How did I forget this? Who asked that question?
That was Lorraine.
Lorraine, you get a prize. Well done for being the secret shopper. How could I forget this? This is such a key important thing. So the vaginal tissues themselves need estrogen to be nice and plump and firm and supporting everything. And that has a role in bladder function too. Because of the way the vagina is constructed, it's quite porous. So for patients who are experiencing urgency and frequency, any itchiness, dryness, things, we will treat them with vaginal estrogen. If we can't give you an estrogen, then we can still give you a vaginal moisturizer. It just doesn't have the same effect. But it's very, very, if you come and see me in clinic and you're a wee bit dry down below, I'll discuss with you whether you want it treated. Even if it's asymptomatic, it's not bothering you, not itchy or sore, I'll discuss whether you want it treated. Lots of patients come in to me and they tell me they've got recurrent thrush. And when I examine them, they don't have recurrent thrush. They've got dry vaginal tissues. So thank you very much for asking that question, Lorraine. And that's important to treat that. It helps with sexual function. It helps with prolapse. It helps with your bladder. It's a good thing to treat.
And Lorraine's saying it's a very big concern for elderly ladies that she works with or volunteers with. So thank you for that.
Absolutely. Get them all, book the bus, get into the GP practice or the specialist physio clinic, but check they're a prescriber. Get in there. And I mean, I famously had a patient one day who came in and she's held up this tube of estrogen and she said, now, they were giving this to every single lady in the clinic. I know, because we all had to wait, and the porter came back with a big box full. And I wasn't sure to use it till I checked with you. And I said, you get that rubbed up there. You know, it's very, very important. And we give it to, you would be amazed. If you have a couple of glasses of wine with your girlfriends and start talking about it, half of them will be on it. And the other half will want to be on it.
I mean, I think one of the things that we're doing here today, Jenny, and your personality is working very much to complement it, is we're giving people an opportunity to ask questions that they don't like to ask or they might not ask. So that's great. And Lorraine's saying that, one of our ladies was treated for a UTI, when really what you're saying is it probably was not a UTI.
It might be. I mean, you get an hour, up to an hour with us. We'll know you better than your own mother by the time that hour is done, right? There's nobody on the face of this earth that knows you better than your pelvic floor physio. So, if we can, and I excuse the pun, we need to get to the bottom of things. We need to spend that time with you. We need to just understand the problem and support you. I was admitted to hospital there myself, did a menopause clinic in the A&E. When I was having a scope in my mum's old ward, everyone was like, great, you're here. We've got a question about your HRT. And it's a great privilege in what I do, because I really enjoy helping people help themselves.
That's so great.
Just don't be afraid to ask the question, but choose who you ask the question of.
Thanks so much. I'm juggling the chat and the Q&A and comments coming in. So thanks so much.
Sorry, I'm quite dry. That's why I keep taking a sip, guys. Sorry.
So there's a question here, Jenny, about, can your physio, is that the person to go to? Can they diagnose bladder pain syndrome, or would that be
it's usually a bit of a combo? It's usually a bit of a combo. You'll usually have seen urology.
Right. Okay.
For that one, and they'll usually have had a wee look in your bladder and stuff. These are more these are straying into the kind of more personalized question.
Yeah.
And it's usually a multidisciplinary approach to the diagnosis.
So here's a bit more of a general sort of question about, those pelvic floor exercises and how you can handle them. And there's a question here about, if you need to go to the toilet during the night, should you go straight away, or as part of your pelvic floor regime, should you try and hold on and wait until you really need to go?
So when we do bladder retraining with you, again, somebody out there, see, look, all the things I forgot to put in here. You're keeping me right, guys. This is fab. So we do a lot of bladder retraining with folks. And we'll have gone through your bladder diary, your 3-day bladder diary, where we ask you to record what you drink and what you eat. And it's a paste. You've got to do it in a jug. It's a paste. There's an app in development in Belgium, but the jug's only wee, so we're not using it super much yet. So your physio will have advised you some techniques to suppress the urge and how and when you're going to do that. And we'll go through it with you, because it's very emotional. Bladder retraining. I'm not being funny when I say that, because you're thinking, oh my God, I'm going to wet myself. And we'll take you through techniques to calm that down and support you to get there on time. Now, we're not saying you need a pee, you're going to stop and you're not going to go for the next hour. We build up. So that will be individualized, and that will all be included in your treatment package.
That's great information there. And there's a question too, Jenny, about someone, I suppose it relates to my points at the beginning around self-management, keeping yourself well, that preventative space. And there's a question just asking about, if you don't really have particular concerns, but you're just thinking, I've had a baby, I want to have good pelvic health throughout my lifespan. Should they do exercises at home, and how do they know that they're doing them correct? How do they know that?
Everyone should be doing them. I mean, we have no problem, with somebody being referred because they're concerned and they want a check. I've seen plenty of people over the years that you see them once, you maybe give them a call, you're all right, yeah, fine, off you go. There's no harm, and I applaud whoever that is that wants to be checked, because you get the best out your pelvic floors by having been checked and have an exercise plan set, because in 99% of cases we don't work hard enough an exercise without some support there. So there'd be no harm in that. You would be very much a routine referral. is what I would say though. So you would have, you know, in terms of a wait, you would have a longer wait, but there's nothing wrong with coming in for a check.
Okay, thanks so much, Jenny. And we've got a few minutes left, and there is one very important question that I've kept to the end, because I think as an organisation, it's something that we feel quite strongly about too. But just to let people on the call know that because we do this at lunchtime, and we know that people sometimes phone in during their lunch break, we do keep very much to time. So just to let you know that we won't run over, and we'll finish by about no later than 1:10. But this last question I think is really important, and it's about how do we get the message out to the next generation? You know, how do we take that stigma out of things? There's a lady on the call saying, you know, I'm going to share this information with my 15-year-old daughter. Lots of people saying,
Well done.
you know, how do we start these conversations, and where do we start these conversations?
I mean, my mum, you know, talked to me about it. You know, she talked to me about it, and so we can blame my mother for me being sitting here today talking to you all. I think she was a midwife who became a scope nurse and spoke to me about it. I speak to my friends openly about things. You know, I have a gynae condition, so you know, I'm quite open about, and I'm not saying splurge your medical details to random strangers in the street, of course, guys, you know, that's not what I'm saying. But I think being, you know, open with your circle, if you're comfortable to do that, is important. I think folks like Davina, Louise, Minchin, Naga have done great work in improving awareness, really great work in improving awareness. So I think us having appropriate conversations, if I can use that slightly prime Miss Jean Brodie type of terminology there, appropriate conversations about what we're experiencing and using those trusted sources of information. Sonia's there's asking, what age can you start at? Well, if someone can understand how to do the exercises, you can start them. I mean, I would say in your teenage years is a good time, you know, just because you're learning about your body, you're learning about your periods. I mean, and that's a whole other talk, isn't it, Irene? We could do about periods and things. But that's, you know, that's a good time. You're learning about it. You're having, you know, kind of sex education, healthy relationship education. That's a great time to bring them in.
And I think the thing is that positive prevention message is there too.
It's always better than cure. Always better than cure.
Exactly. So, you know, having these open conversations in schools and on things like menstrual health and menopause, we're often asked, you know, should we not be having some of these conversations with men as well, so that they understand, you know, the life cycle and the challenges that women can experience? And I think we're getting a bit better at that than we used to be 10 years ago.
Oh, I think so. I have lots of guy friends as well as lots of female friends, and I, you know, my poor guy friends, well, because I mean, I have an interesting job, but you know, but because I also have a health condition and I spend a lot of time mountaineering and stuff, you know, my guy friends have to know about it, you know, because if I'm not feeling very well, they can help me out. So, you know, it's having that appropriate, how do I feel safe to share this information? And we inform those people, and that has a ripple effect. We talk a lot in medicine and you know, health promotion about the ripple effect. And in my clinic in Glasgow, I would often have a patient who came in because their friend had been in for treatment and had found it helpful. So we'd had a word of mouth recommendation. And we would, of course, never let on. They'd say, oh, you saw my friend Doris last year. And you'd always be like, oh, I can't comment on that. And then they'd bring you in a sweetie or something that Doris knows you really like. And they'd just be like, see, told you I know her. You know, so appropriate sharing of information.
Oh, that's great. Well, I mean, thank you so much, Jenny. I think this has been a great session. Thanks to Niamh and thanks to Claire for all their work in the background, and also to Jennifer Stewart, our Senior Development Officer at the Alliance, who's put the programme together, and Sarah from Scottish Government's on the call too, and we're working very closely with Scottish Government and the Women's Health Plan to, you know, action these areas where we feel that we need to shine a spotlight related to women. So just in closing, can I just remind you that we do have a mailing list where you can keep in touch with some of the sessions that we do, and it's WHP for Women's Health Plan at alliance-scotland.org.uk. We'll send around an email to all of you who have joined the session today with further information and just a final signpost to NHS Forum, which has a quite well developed site on pelvic floor. And thanks so much to all of you. You've been great participants today. There's been so much in the chat and so much in the question and answers. It's been challenging to follow all, but I think we've had a great conversation. And, you know, that happens when we have people that can share their experiences with us and ask questions that are so important and relevant. And Jenny, you got a lot of prompts there too, which was really good. So thank you to everyone, and I hope you have a nice rest of the day.
For more information, see the links in the description box below.